Hello friends, I'm to discuss difficulties we may face in extraction of impacted distoangular third molar in mandible. As we know, as per Winter's classification, if the third molar long axis diverges from that of the second molar, it is a distoangular impaction. It is much more difficult to extract due to few reasons. First, we tend to misdiagnose it as a normal erupted tooth, particularly when its occlusal part is at or just above the occlusal part of the second molar. We don't plan surgical extraction. We don't prepare the patient for surgery, and then this distoangular third molar doesn't get even mobile by intraalveolar trials. Many times, crown gets fractured, roots are not visible in direct vision, patient is tired, and we are in urgent need of oral surgeon's help. If we continue without creating adequate distobuccal space for luxation of this third molar, we may end up fracturing angle of the mandible with undue forces. Second, even if we have diagnosed it correct, have prepared everything for surgical approach, the surgery itself is not easy. The path of the removal of distoangular impacted third molar in mandible is towards ramus and external oblique ridge. There is no space for its removal. We need to create adequate space by distal crown sectioning and buccal groove preparation. Now for this, angulation of the micromotor and burr is difficult in this region, particularly if patient does not have good mouth. Then, even after buccal bone groove preparation, adaptation of straight elevator tip between second and third molar to distalize it is not simple because there will be almost no space in between crowns of these two molars at or just below the cervical regions. Many times we need to expand lingual bone within the elevator buccally straight in the prepared groove and rotating the tooth distolingual to distobuccal. This step can fracture lingual bone, compelling its removal if it is too loose. It can lead to laceration of the soft tissues and even injury of the lingual nerve. The third reason, when the crown is fractured completely, it is very difficult to see the roots in direct vision as they lie close and just immediately distal to the roots of the second molar. This makes them most difficult to approach with elevators. Careless, impatient, multiple attempts with elevator can scratch the roots of second molar. Cementum will get destroyed, or even the roots are injured and luxated. This will lead to post-operative sensitivity, mobility, or even non-vital second molar. All these are additional difficulties and complications of extraction of distoangular mandibular third molars. I hope these tips will help in better understanding of importance of diagnosis and surgery planning as a whole. Thank you friends.